Gastroesophageal Reflux Disease, or GERD, is a common condition that affects millions worldwide. It occurs when stomach contents flow back into the esophagus, causing symptoms like heartburn, regurgitation, and sometimes difficulty swallowing. For many, GERD is more than just an occasional annoyance. It can significantly impact daily life, leading to chronic discomfort, sleep disturbances, and even complications like esophageal strictures. While medications such as proton pump inhibitors, or PPIs, are often the first line of treatment, a substantial number of patients continue to experience symptoms despite therapy. This persistent form is known as refractory GERD, and it presents a unique challenge for both patients and healthcare providers. For those with refractory GERD, standard treatments like PPIs often fall short, even when taken as prescribed. About 40% of patients continue to experience troublesome symptoms. This can be frustrating and discouraging, as ongoing reflux can disrupt sleep, reduce productivity, and lower overall quality of life. In these cases, doctors may consider surgical options, such as fundoplication. However, surgery carries its own risks, including post-operative complications like difficulty swallowing, gas bloat syndrome, and diarrhea. These potential side effects make many patients hesitant to pursue surgical intervention, highlighting the need for alternative, less invasive therapies. In response to the limitations of both medication and surgery, endoscopic therapies have emerged as promising alternatives for managing refractory GERD. These minimally invasive procedures aim to restore the function of the gastroesophageal junction without the need for major surgery. Techniques like radiofrequency ablation and transoral fundoplication have shown some success, but their widespread adoption has been limited by technical complexity and the need for expensive equipment. As a result, researchers and clinicians have continued to search for more accessible, effective solutions that can be offered to a broader range of patients. One of the most promising endoscopic treatments is anti-reflux mucosectomy with cap-assisted endoscopic mucosal resection, or ARMS-C. This procedure was first introduced as a cost-effective method for patients who do not respond to PPIs and do not have a large sliding hernia. ARMS-C involves removing a portion of the mucosal lining at the gastroesophageal junction, which leads to scar formation and tightening of the valve, thereby reducing reflux. Unlike traditional surgery, ARMS-C is performed through an endoscope, making it less invasive and generally safer for patients. To better understand the effectiveness and safety of ARMS-C, a prospective, single-centered study was conducted at CHA University Hospital in Korea. The study spanned from 2018 to 2022 and included 96 patients with refractory GERD who had not responded to standard PPI therapy. The primary goals were to assess changes in GERD symptoms as measured by the GERD-Q questionnaire, and to determine how many patients could reduce or discontinue their use of PPIs after the procedure. Secondary outcomes included objective measures like the Demister score, acid exposure time, and esophageal motility. Patients eligible for the ARMS-C study were those who continued to experience GERD symptoms despite adequate PPI therapy. Exclusion criteria included previous esophageal or stomach surgery, pregnancy, major psychiatric illness, large hiatal hernia, and severe esophageal motility disorders. This careful selection ensured that the study focused on individuals most likely to benefit from ARMS-C, while minimizing potential risks associated with the procedure. Before undergoing ARMS-C, all patients received a comprehensive preoperative assessment. This included high-resolution manometry to rule out major motility disorders, 2 4-hour pH monitoring to evaluate acid exposure, and endoscopic examination to assess the esophagus and gastroesophageal junction. The GERD-Q questionnaire was also administered to quantify symptom severity. These evaluations provided a detailed baseline for each patient, allowing for accurate measurement of changes after the procedure. High-resolution manometry, or HRM, is a specialized test that measures the pressure and movement of the esophagus. In this study, HRM was used to evaluate the function of the lower esophageal sphincter and the effectiveness of esophageal peristalsis. This information was crucial for identifying patients with underlying motility disorders, which could impact the success of Arm C. By ensuring that only suitable candidates were included, the study aimed to maximize the safety and effectiveness of the procedure. The GERD-Q questionnaire is a validated tool for assessing the severity of GERD symptoms. It covers 6 key areas: heartburn, regurgitation, sleep disturbance due to reflux, use of over-the-counter medications, epigastric pain, and nausea. Each symptom is rated on a scale from 0 to 3, with higher scores indicating more severe symptoms. In this study, the GERD-Q score served as a primary endpoint, providing a standardized way to measure changes in patient-reported outcomes before and after Arm C. The ARMS-SC procedure is performed using a high-definition endoscope equipped with a distal cap. The area around the gastroesophageal junction is first marked using argon plasma coagulation to outline the section to be resected. A submucosal injection lifts the targeted mucosa, which is then captured and resected using a snare loop and electrosurgical current. The process is repeated as needed to achieve the desired extent of resection. Any bleeding encountered during the procedure is controlled with coagulation techniques, ensuring patient safety throughout. To evaluate the effectiveness of Arm C, researchers focused on both subjective and objective outcomes. The primary endpoints were changes in GERD-Q scores and the number of patients able to reduce or discontinue PPI use. Secondary endpoints included improvements in the Demister score, acid exposure time, gastroesophageal flap valve grade, lower esophageal sphincter pressure, and esophageal peristalsis. Together, these measures provided a comprehensive picture of how Arm C impacts both symptoms and underlying physiology. All data collected in the study were analyzed using established statistical methods. Continuous variables like age, BMI, and GERD-Q scores were summarized as means and standard deviations, while categorical variables such as gender and comorbidities were presented as counts and percentages. The Wilcoxon signed rank test and paired test were used to compare pre- and post-procedure values, with a p-value of less than 0.05 considered statistically significant. This rigorous approach ensured that the study's findings were both reliable and meaningful. The study included 96 patients with a mean age of 47.4 years. Of these, 54 were male and 42 were female. The median duration of GERD symptoms was 4 years, highlighting the chronic nature of the condition in this group. Many patients also had comorbidities such as hypertension, psychiatric disorders, and Barrett's esophagus. This diverse patient population provided a robust sample for evaluating the real-world effectiveness of Arm C. From 2018 to 2022, 120 patients with refractory GERD were assessed for eligibility. After applying strict inclusion and exclusion criteria, 96 patients were ultimately enrolled and underwent the Arm C procedure. The study tracked these patients over time, with follow-up assessments at 6 months and 2 years to evaluate both short and long-term outcomes. This careful tracking ensured that the study's results reflected the true impact of Arm C on patient health. The primary outcome of the study was a significant reduction in GERD-Q scores after Arm C. On average, scores dropped from 10.67 before the procedure to 7.55 afterward, indicating a marked improvement in symptoms. This change was statistically significant, with a p-value less than 0.001. These results suggest that Arm C can provide meaningful relief for patients who have not responded to standard medical therapy. Another key finding was the reduction in reliance on proton pump inhibitors after Arm C. Out of the 96 patients, 36 were able to either reduce their PPI dosage or stop using PPIs altogether. This is a significant outcome, as long-term PPI use can be associated with side effects and increased healthcare costs. For many patients, reducing or eliminating the need for daily medication represents a major improvement in quality of life. The Demista score is an objective measure of acid exposure in the esophagus. In this study, the median Demista score improved from 4.75 before Arm C to 3.9 after the procedure, with a p-value of 0.023. This reduction indicates that Arm C not only alleviates symptoms, but also reduces the underlying acid reflux that causes damage to the esophagus. Acid exposure time, or AET, measures the percentage of time the esophagus is exposed to acid. After Arm C, the mean AET decreased from 2.81 minutes to 2.07 minutes, with a p-value of 0.033. This improvement further supports the effectiveness of Arm C in reducing harmful acid reflux and protecting the esophagus from ongoing injury. The gastroesophageal flap valve, or GEFV, is an anatomical structure that helps prevent reflux. In this study, the median GEFV grade improved from 2 to 1 after Arm C, indicating a tighter, more effective barrier against reflux. This anatomical change is a key reason why patients experience fewer symptoms and less acid exposure after the procedure. The lower esophageal sphincter, or LES, is a critical muscle that prevents stomach contents from flowing back into the esophagus. After Arm C, the mean LES pressure increased from 18.42 mm² to 21.13 mm². Although this change was not statistically significant, it suggests a trend toward improved sphincter function, which may contribute to the overall reduction in reflux symptoms. Esophageal peristalsis refers to the coordinated muscle contractions that move food and liquid down the esophagus. In this study, the proportion of patients with intact peristalsis increased from 78.4% before Arm C to 89.7% after the procedure. This improvement was statistically significant, with a p-value of 0.002, indicating that Arm C may help restore normal esophageal motility in addition to reducing reflux. Beyond overall GERD Q scores, the study also examined specific symptom subcategories. The frequency of heartburn, reflux symptoms, and sleep disturbance all showed significant improvement after Arm C. For example, heartburn frequency dropped from 1.95 to 1.1, and reflux symptoms from 1.98 to 0.91. These improvements highlight the procedure's ability to address the most bothersome aspects of GERD. To assess the durability of Arm C, the study followed a subset of patients for at least 2 years after the procedure. Among these patients, 86% continued to show improvement in symptoms, with many able to maintain reduced or no PPI usage. Importantly, no serious adverse effects were reported during long-term follow-up, suggesting that Arm C offers lasting benefits for most patients. Patients were categorized into 3 groups based on their response to Arm C: complete response, CR, partial response, PR, and no response, non. CR patients showed both symptom improvement and reduced PPI usage. PR patients had improvement in either symptoms or medication use, and NR patients showed no improvement. Out of the total, 86 patients fell into the CR or PR categories, while only 10 showed no response. This distribution underscores the high success rate of Arm C in this patient population. Safety is a critical consideration for any medical procedure. In this study, Arm C demonstrated a favorable safety profile. Serious complications were rare, with only a few cases of esophageal bleeding and simple strictures, all of which were effectively managed with standard treatments. No patients experienced long-term adverse effects, and the overall rate of complications was low compared to traditional surgical options. ARM-C stands out among endoscopic therapies for its balance of effectiveness, safety, and cost. While procedures like the stretta and endoscopic suturing offer alternatives, they often require expensive equipment or have less durable results. ARM-C, by contrast, is more accessible and does not require general anesthesia or the placement of permanent devices, making it a practical choice for many patients and healthcare systems. The effectiveness of ARM-C is rooted in its ability to induce scar formation at the gastroesophageal junction. By removing a portion of the mucosal lining, the procedure tightens the valve and enhances the barrier against reflux. This anatomical change not only reduces symptoms, but also improves esophageal motility and acid clearance, as reflected in the study's objective measures. One of the notable findings from the study was the improvement in esophageal peristalsis after ARM-C. Among patients with initially ineffective motility, a significant proportion showed restored peristalsis on follow-up testing. This suggests that ARM-C not only addresses the mechanical barrier to reflux, but may also help normalize esophageal function, contributing to better symptom control and esophageal health. Importantly, the study found that ARM-C did not degrade the function of the lower esophageal sphincter. LES pressure remained within the normal range after the procedure, indicating that the intervention strengthens the anti-reflux barrier without causing harmful side effects. This finding supports the safety and physiological soundness of ARM-C as a treatment option. While ARM-C proved effective for most participants, the study did not identify specific pre-procedure parameters that predicted a good response. This means that patient selection should continue to be based on clinical judgment, focusing on those with refractory GERD who have not responded to medication and do not have contraindications such as large hiatal hernias or severe motility disorders. ARM-C offers significant economic and practical advantages over other endoscopic and surgical treatments. It is less expensive, does not require general anesthesia, and can be performed with standard endoscopic equipment. These factors make ARM-C an attractive option, especially in healthcare settings with limited resources or where access to advanced technology is restricted. Compared to traditional anti-reflux surgery, ARM-C is less invasive and associated with fewer complications. Surgical procedures like fundoplication can lead to issues such as dysphagia, gas bloat, and diarrhea, which are less common with ARM-C. For patients who are not candidates for surgery or prefer to avoid it, ARM-C provides a valuable alternative that delivers comparable symptom relief with a better safety profile. Despite its promising results, the study had some limitations. It was conducted at a single center and did not include a randomized control group, which may limit the generalizability of the findings. Additionally, while long-term follow-up was performed for some patients, more data are needed to fully understand the durability and safety of ARM-C over many years. Looking ahead, future studies should aim to include larger, multi-center populations and randomized control groups to validate the findings of this study. Continued research will help refine patient selection criteria, optimize procedural techniques, and further establish the long-term safety and effectiveness of ARM-C. As the field of endoscopic therapy continues to evolve, ARM-C is poised to play an increasingly important role in the management of refractory GERD. For patients, the experience of undergoing ARM-C is generally positive. The procedure is performed endoscopically, often without the need for general anesthesia, and recovery times are typically short. Most patients report significant relief from symptoms, reduced reliance on medication, and minimal discomfort during and after the procedure. These factors contribute to high patient satisfaction and acceptance of ARM-C as a treatment option. ARM-C is increasingly being recognized as a valuable tool in the clinical management of refractory GERD. Its safety, effectiveness, and accessibility make it an appealing option for patients who have not found relief with medication and wish to avoid surgery. As more clinicians become familiar with the technique, ARM-C is likely to become a standard part of the therapeutic arsenal for GERD. The economic impact of ARM-C extends beyond individual patients. By reducing the need for long-term medication and avoiding costly surgical interventions, ARM-C can help lower overall healthcare expenditures. Its cost-effectiveness makes it an attractive option for healthcare systems seeking to provide high-quality care while managing resources efficiently. Improving quality of life is a central goal in the treatment of GERD. ARM-C has been shown to significantly reduce symptoms like heartburn and regurgitation, allowing patients to enjoy better sleep, increased productivity, and greater overall well-being. For many, the ability to reduce or eliminate daily medication is a major benefit, freeing them from the burden of chronic therapy. GERD is a global health issue, affecting people of all ages and backgrounds. The accessibility and affordability of ARM-C make it a particularly valuable option in regions where advanced surgical or endoscopic equipment may not be readily available. By offering a safe and effective solution, ARM-C has the potential to improve GERD care worldwide. In summary, ARM-C offers a safe, effective, and accessible treatment for patients with refractory GERD. The procedure leads to significant improvements in symptoms, reduces the need for medication, and has a low risk of complications. Both short and long-term outcomes are favorable, making ARM-C a valuable addition to the range of options available for managing GERD. Many patients who have undergone ARM-C report a dramatic improvement in their daily lives. They describe relief from persistent heartburn, better sleep, and the freedom to enjoy foods that previously triggered symptoms. These personal stories highlight the real-world impact of ARM-C and reinforce the value of this innovative procedure. Gastroenterologists and endoscopists are increasingly recommending ARM-C for patients with refractory GERD. Experts emphasize its safety, effectiveness, and the growing body of evidence supporting its use. As more clinicians gain experience with the technique, ARM-C is expected to become a mainstay in GERD management protocols. Research into ARM-C and other endoscopic therapies for GERD is ongoing. Studies are exploring ways to optimize the procedure, identify ideal candidates, and compare outcomes with other treatment modalities. This ongoing work will help ensure that patients receive the most effective and individualized care possible. In conclusion, ARM-C represents a significant advancement in the treatment of refractory GERD. Its minimally invasive nature, strong safety profile, and proven effectiveness make it a compelling choice for patients and clinicians alike. As research continues and experience grows, ARM-C is poised to become a cornerstone of GERD management, offering hope and relief to those who need it most. As we look to the future, ARM-C offers new possibilities for patients struggling with GERD. Its combination of safety, efficacy, and accessibility makes it a standout option in the evolving landscape of gastrointestinal care. For those who have not found relief with medication or wish to avoid surgery, ARM-C provides a path forward, one that promises better health, improved quality of life, and renewed hope.